Hello, welcome back to Align and Energize. I'm Sandy Kim, PharmD, longevity practitioner. And the person on the other side of the camera, we have another PharmD with me, Grace Magedman. She spent more than 2 decades inside hospital pharmacy leadership, including chief pharmacy officer at Chalk, Orange County. She trained in functional medicine through Institute of Functional Medicine. She's not someone who learned about pharmacy and got interested in women's health. She's a pharmacy executive who spent nearly 2 decades inside the healthcare system. And then her own body told her a story that her annual exam never caught. That gap between what the system offers and what women actually needs is where her work lives. So, Grace, what's the story you want our audience to hear first?
Yeah, Sandy, thank you so much for inviting me here to be with you and your community today. Here's what I want to do in the next, 30, 45 minutes, however long we have. I want to have a conversation that your last appointment probably didn't make time for. And it's not because your doctor's not good at what they do. It's because the system that they practice inside isn't designed to look at your biology in the same way, right? Or in the whole way. It was designed to find a problem, name it, treat it, and off you go, right? Off they go to the next patient. And that's a very different thing from asking why. And that word why is where everything we're going to talk about today lives. So I'll start with a really personal story, actually, because I think it's the fastest way to show you exactly what I mean. A few years ago, I was in the middle of a significant health crisis, and I had been dealing with prolonged and heavy bleeding that was affecting my ability to work function day to day. And I was exhausted and anxious in a way that was just more than physical. It was even, emotional. And I was struggling in ways that I didn't have words for yet. So I
Mhm,
went to see my provider, as we all would, right? And
mhm,
she handed me a prescription for antidepressants. Now, I'm a
mhm,
pharmacist. I've spent over two
mhm,
decades understanding what medications do and what they don't do at the molecular level, right? Like I knew exactly
mhm,
what that prescription was, and I also knew exactly what it wasn't going to address. But
mhm,
when you're really depleted, there's a part of you, especially when someone just holds out something that looks like an answer, there's a part of you that kind of wants it to be the answer. But
mhm,
I pushed for more investigation because it wasn't like we weren't addressing the biggest thing in the room, right? And so eventually I saw my gynecologist and we found something in scans. And then he looked at me and he said, and I'm going to quote him directly, let's just cut it out.
mhm,
Those were his exact words. And I remember sitting in that room thinking, nobody has asked a single question yet about why any of this is happening. Not about the bleeding, not about the anxiety, not about the exhaustion,
mhm,
not about any
mhm,
of it. And nobody had looked at the whole picture as a connected system. And that was
mhm,
a moment where I understood the difference between a medical system that treats problems and a framework that
mhm,
investigates people, right, as a whole.
mhm,
And so everything
mhm,
that I do now and everything we're going to talk about today it comes from that understanding. So
mhm,
let me start with what functional medicine actually is, because there's a lot of noise around that phrase, and I want to be
mhm,
really precise with you. Some people call it integrative, some people call it functional medicine, some people call it longevity medicine. They all have a little bit of their different emphasis, but at the end of the day, it's more about the root cause and a holistic view of the body. So
mhm,
if we think about conventional medicine, right, it's extraordinary at certain things. If you have an
mhm,
acute infection or you've got an emergency or trauma care or even diagnosing a heart attack, that's where you
mhm,
want to go, right? It is one of the most important systems human beings
mhm,
have ever built. But where it has some real limitations is in the space where something is clearly wrong and your
mhm,
labs look fine, right? That's the
mhm,
space where most of the women probably listening right now actually live.
mhm.
And so
Oh
functional
yeah.
medicine
Mhm,
asks a different set of questions. It asks not what disease do you have, but what's happening in this whole biological system. And it's not
mhm,
about just what symptom do we treat. Yes, we absolutely listen for that. But what is
mhm,
upstream of what you're
mhm,
experiencing? Because that may sound really simple as far as that distinction goes, but how we treat it or how like the clinical implications of it are enormous. So both
Mhm.
Sandy and I come to this from the same clinical training, right? We're both pharmacists. We're both
Mhm.
educated to understand how drugs work at the molecular level, and whether it's how they bind to receptors or metabolic pathways, and how they're metabolized, and what the med does and doesn't do. And that
Mhm.
training is really precise and very, very valuable. What it didn't
Mhm.
really prepare us for, though, is that we both eventually observed in our clinical practices that patients would be on 5, 8, 10 plus medications, and no one's systematically asking, like, what is driving the need for all of them? And so,
Mhm.
limited time, very hard, probably not very much time to have meaningful conversations around lifestyle, nutrition,
Mhm. Mhm.
deprescribing, or reducing the number of medications someone is on.
Mhm.
That's oftentimes like optional rather than an active clinical goal. And so the pattern of reaching for that next band-aid, that next intervention, when the one before is no longer, is kind of what we see in mainstream healthcare. As pharmacists, we were trained to understand the mechanism of the treatment, but functional medicine asks us to look upstream of that treatment.
Mhm.
Why has the system made it necessary in the first place? So that
Right.
shift is, what this conversation is all about.
Great. That's amazing. Yeah, it's good that you explained thoroughly about what functional medicine is. And just want to know, get an idea, like how did you go from chief pharmacy officer to functional medicine practitioner? And was there any turning point for you, how you made that transition?
Yeah, that turning point obviously was really personal, right? I mean, it is for all of us when we have pivots in our lives. I described what happened at the beginning, right? And what I didn't say yet is that functional medicine eventually helped me find a partner to help me ask why. The
Mm-hmm.
the HPA axis dysregulation, what we call hypothalamic pituitary adrenal axis, right? This whole cortisol system and everything that was completely
Mm-hmm.
dysregulated,
Mm-hmm.
hormonal disruption, um, thyroid dysfunction, gut-driven anxiety, all of that, estrogen dominance. You add that in, and that was
Mm-hmm.
all happening at the same time, but no one was treating it like a connected picture. You go to the gynecologist
Right.
for your reproductive
Mm-hmm.
issues. You go to the
Mm-hmm.
rheumatologist for your joint issues. You go to the cardiologist for your heart
Right.
issues, right? Um,
Yeah.
what I realized, though, is that the environment that I was working within was the same environment that I got sick in was not the one that I could also heal in. And so it really
Mhm.
required me to get honest with myself and
Mhm.
evaluate my values and what
Mhm.
my life was playing out to be, whether they were in alignment with those values or not. And I
Mhm.
got two boys, and one's a lot older, one's a bit younger. Adam, my husband, maybe that's what they're just kidding. But I want to be there tomorrow and the next day and the next
Mhm.
decade
Yeah.
to be present and available and accessible and living life with them. And I knew
Mhm.
that if I was going to continue on that pace, in that same role, in that same structure, in that same environment, that
Mhm.
tomorrow might not come. Right. And so
Right. Right.
um, that was my turning point, and functional medicine really helped me figure out what the heck was going on with my body and how
Right.
do I change this trajectory that my body's on.
Mhm. Wow, thanks for sharing such a, personal but very open story. I think a lot of moms are going to relate to your story too, that they want to be present with their loved ones, right? For their families. And definitely, this is very relatable too. And just a lot of audience will wonder, like, what does functional pharmacy or functional medicine pharmacy visit looks like compared to the regular doctor's appointment or any other appointments?
Yeah, that's a great question. You all know what your primary care physician or provider
Mhm.
visit is like, right? Um,
Mhm.
I don't necessarily need to describe that there. I would say the
Mhm.
biggest distinction is the intake alone. And it's unlike anything most people have experienced. And when I take my clients through this, it's this eye-opening, empowering kind of aha moment. But I spend, good 60 to 90 minutes just on someone's biological timeline and what we call the functional medicine matrix. So we see the body not as just single parts and silos, but as functions and systems that talk to each other,
Mhm.
that impact one another. And so, for example, one part of the matrix, we call them nodes, right? One part of it is assimilation. We'll talk a little bit, Sandy will talk a little bit about the gut and the digestion and absorbing what you're actually eating. And another part is elimination, detoxifying, pooping, if you will, what you're ingesting, but detoxifying the things in your body that need to get released so it doesn't hang on to get sick. And again, those two are connected, even though we don't always have them in the same sentence, right? And so the intake encompasses not only your current symptoms, but your whole history. What were some of the predisposing factors in your childhood, whether it's within your, infancy or beyond? Was there a triggering event that all the symptoms started after? And what's causing the symptoms to continue? We also, obviously, from a pharmacist lens, we take a look at what medications have you been on and for how long, because that context is what tells you what's been accumulating over time. And so we map out what part of your physiology is signaling the loudest. And most providers have 15 minutes, right? And we have the luxury of asking the full question over the longer period of time.
Right. That's great that through functional medicine, they have an option to look at the whole picture compared to individualized system. They will also wonder, is this service covered through insurance and how do they access it?
Yeah, most functional medicine services right now are not covered by standard insurance. And that's a real access issue that, I obviously want to be honest about. Most offer a private pay model. And I think the ultimate vision that I would love to see is that functional medicine is part of a covered insurance program, if you will. I think of it as like healthcare versus sick care, right? But, the private pay model is, what I offer to, probably Sandy does too. And it's designed to be the first accessible step. It's not like everything's going to change in one sitting. It's like meds don't fix everything overnight either, but it is mostly private pay, which means it's out of pocket. And so if you do have, some providers are able to kind of help you access HSA and FSA funds, but it's a process for each of those practices too. And so, it's, we'll get there, hopefully.
Sure. Yeah, hopefully. Yeah. All right. So moving on, let's look at three places right now where the different lenses changes everything. And we're going to start with something that just broke in the medical literature pretty recent, right?
Yeah. 2 weeks ago, almost exactly. Well, actually, okay. So let me pause because who knows when this goes out, but in the middle of this month on May 12th, after years of research, over a decade of research and input from 22,000 stakeholders, their patients, clinicians, researchers, the Lancet, which is a very reputable medical journal, formally renamed PCOS, polycystic ovary syndrome. And it's now PMOS, which is polyendocrine metabolic ovarian syndrome. Now, this, and forgive me up front because I'm going to say PCOS all the time because that's what I'm used to.
So used to it.
And so if I say PCOS, PMOS, I mean PMOS, right?
PMOS.
But it's a condition, it's a chronic condition that actually affects 1 in 8 women. So it's not rare. And that means somebody in this community who's listening right now might even have it. Again, I actually have PCOS or PMOS, right? And so this is near and dear to my heart, which is why I kind of track on this carefully. And that name change, though, I think of it as a structural correction to a foundational clinical error. And so let me explain what I mean by that. The old name, polycystic ovary syndrome, implies that the problem is with the ovaries, that you have cysts on your ovaries that, create all of these androgens like testosterone and androstenedione that causes all these these symptoms that we're experiencing. And so for decades, clinicians evaluated just the ovaries. And so if your ovaries were fine on ultrasound, then you're okay, right? No diagnosis, if you will. And it's not like we're looking for a diagnosis, but it helps us understand what are we trying to accomplish? What are we trying to treat? Well, it turns out that what looked like cysts on the ovaries were actually normal follicles, because the body is trying to create and release these follicles, and they just and it looks like this classic string of pearls, but they're not cysts. It's just normal function, and your body trying to compensate for that.
Right.
What we know is that the real driver is actually hormonal and metabolic. That's why it's polyendocrine, right? So you've got
Mhm.
elevated androgens, you've got insulin
Mhm.
resistance, and a whole
Mhm.
cascade of effects on weight
Mhm.
and blood sugar and mood. And it shows up in your skin. For many
Mhm.
women, it comes up as cystic acne,
Mhm.
that is just resistant to so many things. Comes up
Mhm.
as like hair in places that you don't want it, like on your face, right? And some
Yeah.
people have peach fuzz. Some people have like full on, chin
Yeah.
hair.
Yeah.
Others will have hair loss because of
Mhm.
the receptors that are, it's kind of why men go bald because they have all this testosterone,
Mhm.
HT. Well,
Right.
women are
Yeah.
sensitive to that too if our,
Mhm.
levels are out of range. And so,
Mhm.
obviously, it impacts fertility too because
Mhm.
the ovary is being impacted at that point. But
Mhm.
70% of women, it's like the WHO, the World Health Organization, has kind of estimated that more than 70% of women with PMOS have it and they don't even know. And it's not
Ooh,
because
wow.
they didn't go to a doctor for it. It's just because that clinical framework was built around the wrong structure. So,
Mhm.
what does that mean for us now? Well, does that mean all the treatment guidelines have changed all of a sudden? No, unfortunately,
Mhm.
there's a process, and a lot of this is kind of slow to start. But it
Mhm.
does raise awareness around what are the questions we're actually asking. Is it truly about the ovaries? Because there's actually 4 different presentations of PCOS or PMOS, and in
Mhm.
some cases, there are no cysts on the ovaries. Like
Mhm.
I didn't have any cysts on my ovaries, but my doctor and I, we worked so closely together to figure out why the heck this was happening.
Right.
And just a side note, believe it or not, yes, I probably had the genetic predisposition for it, but I kind of created it for myself. And there was a period of time, and I'll share with you why, right? This is the geeky part of me. But
Mhm.
there was a period of time in my life where I was under a really high amount of chronic stress at work.
Mhm.
My outlet was to run marathons and train for marathons. Well, if you've
Wow.
ever trained for any races, you know that even running for long periods of time is a form of stress, right? And
Yeah.
anyone in that runner's world will remember or will have heard at some point in time something called carbo loading. So we eat all
Mhm.
these carbs and we fuel ourselves and then
Mhm.
we go for a run. That's the
Mhm.
worst thing a PCOS predisposition woman can do. But
Oh.
again, we don't know, right? Because what
Yeah.
happens? You eat the carbs, the insulin skyrockets to try to bring the blood sugar down, and
Mhm.
then and what I didn't know then that I know now, obviously, is that our ovaries have these cells on them called theca cells, and they also have insulin receptors on them. So the more
Mhm.
insulin you have, the theca cells generate more androgens, more testosterone,
Mhm.
more,
Mhm.
androstenedione, DHT conversion to it. And so it was
Mhm.
no wonder that I started to get peach fuzz. I started to get acne. I
Oh.
got midsection weight gain, which is the worst,
Mhm.
right? It's not just the flabby
Mhm.
kind, it's what we call central adiposity. And that
Mhm.
is the inflammatory, very metabolically active kind of fat that we don't want, even though I was lean.
Mhm.
So
Wow.
um, the good news about PMOS is that it helps us kind of dig a little bit deeper around what is that hormonal, metabolic, and endocrine picture for the woman. Um,
Mhm.
but the treatment, approaches haven't quite changed yet. So hopefully we'll get there.
Yeah, hopefully, definitely. Wow, thanks for sharing the details. Hopefully will give more awareness to our audience and to public. And what should women who are diagnosed with PCOS or PMOS actually ask their doctor now?
Yeah. So one of the things, well, depending on your doctor, your provider, and the relationship you have with them and how much time
Mhm.
they have,
Mhm.
don't let the time thing um,
Mhm.
make you back away. It is your
Mhm.
time that you are there for and for
Mhm.
your care. So don't be, it's not selfish to ask about these
Right.
things.
Yeah.
Oftentimes they'll throw a pharmaceutical intervention at you, right? There's birth control pills that they'll say, let's just,
Mhm.
manage your cycle. And there's
Mhm.
reason for that, but that's not always the answer either.
Mhm.
There's, things like spironolactone for some of the skin conditions. And then there's like metformin, for example, that will help with some
Mhm.
of the blood glucose modulation, insulin
Mhm.
sensitivity. I would
Mhm.
ask though about what else,
Mhm.
if we took a step back, what else within my picture is
Mhm.
signaling to us to take a look at
Mhm.
that we need to take a look at in a deeper way. So is there something more metabolic that we need to look at, something more hormonal? And you could even ask them for additional panels to just kind of do a full assessment of what is going on within your body. So
Right. Great. Yes, definitely. That's a good information to have. And what kind of labs would you actually ask for the standard care or OBGYN visit might not?
yeah, few come to mind, but the first couple is fasting insulin. And,
Hmm.
we always get our uh, fasting glucose is a standard lab. Like everybody runs that all the time. Even
Hmm.
hemoglobin A1C is a pretty standard panel for most people,
Right.
for pretty much everybody. But
Right.
again, these are snapshots.
Hmm.
HbA1c will tell you what the last 90 days of your glucose did, but there are plenty of
Hmm.
PMOS women who have normal blood
Hmm.
glucose, but they might not have normal insulin. So you want to check a
Hmm.
fasting insulin. This will tell you,
Right.
is your body putting out all this insulin to try to bring down that blood glucose? And if it is,
Hmm.
that's part of the
Hmm.
picture. I'd also
Okay.
want to understand what my androgen panel is. And so and that not only includes like free testosterone, but your total testosterone and something called sex hormone binding globulin. And of course, you want
Hmm.
to see your estrogen progesterone too.
Hmm.
Just remember that these are snapshots. Those are snapshots, right? So it doesn't
Hmm.
necessarily tell you what's happening over the course of time, but it's just where are we
Hmm.
today?
Hmm.
If you have, like, for example, a high estrogen levels, your
Hmm.
sex hormone binding globulin will go down, and
Hmm.
actually it'll go up. Well, so anyways, it will go up because it wants to bind all the hormones that are around, but it has an
Hmm.
affinity for testosterone. Now, I pause there because when estrogen goes up and SHBG goes up, your testosterone goes down, which is not the picture of
Hmm.
PMOS.
Hmm.
But it could be the alternative, right? Like you could still have PMOS and estrogen dominance and all these other things going on, which again is something that I had. And so you have to take a look at the bigger picture, because even at the what were normal testosterone levels
Hmm.
for a person, for a normal woman,
Hmm.
it's still, if it's still presenting in
Hmm.
highly androgenic patterns,
Hmm.
you still have to get it checked out, right? Like that's not a reason to say, oh, well, because the number is
Yeah.
normal, we'll just leave it at that. You're still struggling with the
Okay.
symptoms, right?
Oh.
Comprehensive thyroid panel, as well as inflammatory
Mhm.
markers. And HSCRP, high sensitivity CRP, is one that kind of gives us a good picture of chronic inflammation. Here's the thing about
Mhm.
PMOS, and it's really, really frustrating. Um,
Mhm.
it's a chronic condition that's marked by insulin resistance. It doesn't matter whether
Mhm.
you're obese or not, right?
Mhm.
And it's also marked by inflammation. Now,
Mhm.
inflammation causes insulin resistance. Insulin
Mhm.
resistance causes inflammation. So it's this vicious cycle that we have to be able
Cycle.
to break, right?
Yeah.
And all of that, one of the things that most providers also don't look for in PMOS is what's happening in the gut. Like the gut actually
Yeah.
drives a lot of hormonal dysregulation in PMOS. And so, in a variety of ways that we won't necessarily dive into deeper now, but I think this is a great place to talk about the gut because that's really right up Sandy's
Mhm.
lane.
Yeah, yeah, definitely. Before we move on to the gut part, just from a PMOS standpoint, how does this connect with the mental health piece? I know you briefly touched upon from your experience too. Do they, because a lot of women with the PMOS also struggle with anxiety or depression. Any thoughts on that? Maybe brief touch upon, yeah, that mental
Certainly.
piece.
Yeah. As I mentioned, the gut driving some of the hormonal dysregulation in PMOS, and again, Sandy, this is right. This is where she really works. The gut is also where our neurotransmitters are going to, the production of our neurotransmitters are going to be really impacted. And so
Mhm.
when
Okay.
there's that gut disruption or dysbiosis, what we call it, that
Mhm.
will impact the way that our bodies produce the neurotransmitters and everything that we need to kind of maintain good
Mhm.
mental health. And so
Mhm.
there is definitely a connection there
Right.
between, PMOS, gut health. And,
Mhm.
at the end of the day, when you've got PMOS too, you don't feel great, so you kind of add
Mhm.
that into the
Yeah.
hormonal dysregulation, and it's
Mhm.
just a recipe for
Yeah.
for a very frustrated woman. And so, and it's really understandable that she's going to be moody.
Yeah, they're all connected, definitely.
Yeah.
So yeah, let's talk about the gut part. Like you did mention, they're all connected. And gut, yes, it is a neuroendocrine organ running continuous two-way conversation with the brain, immune system, and the hormonal axis, as Grace just mentioned. And when the gut environment is disrupted through dysbiosis or intestinal permeability, food sensitivities, or chronic inflammation, those effects show up in, like you said, mood, cognition, energy, or immune system, resilience, hormonal imbalance. So they all connected. And a lot of our audience, like working moms specifically, they do have that chronic stress actively going on. It impairs their intestinal lining and it will shift their microbiome composition and also drives the cortisol elevation. And this cycles back to itself, like ongoing, right? So the mental health symptoms often have that biological root that have never been studied or investigated a lot. The anxiety that starts in the gut, the brain fog that is driven by inflammation, and the mood instability, and that's also related to the hormonal shift. And I wanted to touch briefly also about the women. A lot of my clients over 40, usually when they go to the doctor's office, they come with a lot of the symptoms already with the reflux. So they end up starting the proton pump inhibitors. A lot of them also on birth control for years. And they are on sometimes antibiotics, NSAIDs by the time they're 40. Also, some mood, so SSRIs are just very common medications. But these medications, if you think about it, it can shift, for example, the PPIs. It shifts the stomach acid balance and making it harder to absorb, for example, the vitamin B12. For example, antibiotics that can wipe out the gut microbiome diversity and the birth control. They can also change how they process the estrogen. The NSAID, for example, they can create the ulcer in the gut lining, and the SSRI can affect the gut based serotonin level too. So, all of these medications they are already taking are causing some other imbalance in our system too. And these part, I want to point it out that these are something that you want to pay attention to. If you do have any of the symptoms with the previous medical history, that's something that I want to let my audience know that to get it checked, either through a practitioner or functional practitioner like ourselves, to get a whole picture of what's actually happening in our body. So I just want to point that out. Like you mentioned, gut is very important, and a lot of things are already impacting our gut health. So it's very important to aware of those importance and also be aware of your own symptoms. If it's not regular, if something off and you know it's off and you want to get it checked, I really do think our women should not just hold on to it, but to see the care for it.
For sure.
Yeah.
Sandy, for the woman who is recognizing herself in this, kind of going through a checklist, like,
Mhm.
oh, yeah, I meet those, all the things that Sandy's been
Yeah.
talking about. Um, what's
Yeah.
one thing that she can start
Mhm.
doing today before any
Mhm.
supplement or medication change?
Yeah, I would say simply noting that she feels something after eating, for example. Do you feel
Mm,
calm or do you feel something's off? It feels sharper or a little louder than usual. That awareness is the first step, I would think. And from there, we can consider restoring the balance, and diversity of the microbiome is very important. It's also factory for the serotonin and dopamine, that other neurotransmitter that are important for us. So just be aware of your own symptoms, and recognizing it would be the first step I would take.
Awesome. Now, how do you figure out if
Mhm.
someone's anxiety is gut driven
Mhm.
versus something
Mhm.
else?
Yeah, I would say if she tells me her mood shift after the meals, and if she already has like a history of bloating or skin issues, and if her anxiety feels more like a physical wired but tired state rather than like just situational stress response, then that tells me gut can be that driving reason for that symptom. So that's how I would um, think that it would be
Yeah.
gut driven
Gotcha.
anxiety.
Gotcha. Yeah, and
Mhm.
what Sandy just described, the gut environment being actively disrupted by stress and by medications and really just the cumulative load of a high demand life, brings me to
Mm.
the one of the dimensions of the functional resilience framework that most people don't really think
Yeah.
about when they think of the gut, and that's
Mhm.
environment, right? The gut isn't just affected by what you eat or the stress you feel. It's the entire environment that you're in. So it's the toxins in your
Mhm.
water or your food packaging. And we hear a lot about
Mhm.
microplastics. It's the
Very
personal
well.
care products on your skin. How many,
Mhm.
TikTok influencers do we see promoting the next new Korean skincare, which I love all, by the way.
Yeah,
But like,
skincare.
what's in it? Are there
Mhm.
phthalates and other things and BPA and all
Mm.
that is
Mm.
actually, mimicking estrogen? It could also be as
Mhm.
simple as the light in your bedroom at midnight, and the timing of your
Mhm.
meals relative to
Mhm.
your actual circadian rhythm. So, my
Yeah.
guess is that many of you moms probably snack off your kids' plates,
Mhm.
right, as they eat, and
Mhm.
you don't necessarily take the time to eat a full meal on a regular basis.
Mhm.
um, that actually
Yeah.
does a number to your gut too, right? Because the bacteria, the gut
Mhm.
microbiome, actually has
Mhm.
its own circadian clock. And so
Right.
when we're constantly sending it inconsistent messages,
Mhm.
it can disrupt, our gut too. And so that environment piece is a really important thing to kind of keep in mind.
Yeah, that's very important point that Grace shared. A lot of moms will probably very relate to that. And having that right environment for you is very important. Yeah, that's thanks for sharing that
Mm.
also. And we want to shift to something that women in this age group are not paying nearly enough attention to. And I say that not to scare anybody, but because the data is important to not skip over. So I want to uh, ask you about any of your insights on the heart part, heart health in women.
Yeah, I think that's such a great topic, Sandy, because heart disease is the leading cause of death in women in the United States, and it has been for
Mhm.
decades. So let me say
Mhm.
that again. It's the leading cause of death in women, not breast cancer, not any of the things that we are tested and screened for most aggressively. It's heart disease. And it's
Mhm.
so frequently missed. In fact, last year, 2025, BMC Public Health issued they did a study taking a look at a couple of decades worth, actually 1 decade, 10 years of
Mhm.
public health data. And in it, they found that 63% of women who had angina or like chest pain, that
Mhm.
diagnosis, it was missed. And
Mhm.
if we think about it, like the way in which they're evaluating it, because it's based on a male model, a male framework, that number is
Mhm.
probably a lot higher, right? And so
Mhm.
women's physiology is not men's physiology. We are not just little men, right? We have a
Mhm.
whole host of additional um, I mean, yes, they have hormones too. They have estrogen, progesterone,
Mhm.
all that too. But ours is just so much more complex in a
Right.
beautiful way that
Yeah.
whatever was kind of built for a man is not necessarily going to apply to us. And so,
Mhm.
um, women's cardiac symptoms often look different. We all know of the classic heart attack, not heartache, but the
Mhm.
heart attack symptoms like chest pain and what have you on the left hand side. But for women, can look very different. It could just be
Oh.
profound fatigue that doesn't necessarily recover with rest. It could be
Mm-hmm. Mm-hmm.
nausea, shortness of breath. It could be jaw pain and
Mm-hmm.
anxiety. These aren't that classic, crushing chest pain kind of symptom that every cardiac awareness campaign is, putting on a poster. And so
Mm-hmm.
when a woman goes to the emergency room with those symptoms, fatigue and nausea, the probability that her cardiac status is going to be fully investigated is
Mm-hmm.
probably a lot lower than a
Mm-hmm.
male, a man patient presenting with similar symptoms. And that's not hypothetical. That's actually current peer-reviewed literature. So, like
Oh.
all the diagnostic tools, the stress tests, the
Mm-hmm.
risk calculators, the standard lipid panels, they're all validated in populations that didn't necessarily represent fully the female physiology. And that's a
Mm-hmm.
systems problem, right? And it's
Yeah.
and knowing that changes what we ask for. And so,
Mm-hmm.
you know, there's a connection to estrogen. Why is it important, especially in this age and stage of life?
Mm-hmm.
Estrogen is actually a beautiful and cardioprotective hormone.
Mm-hmm.
And our cardiovascular system depends on it in so many different ways that, again, most annual exams don't address. A decade before menopause, not decades, let's not go that far. That's the time frame where most women start to experience these massive fluctuations in estrogen. And
Mm-hmm.
when that happens, that the whole cardiovascular picture starts to shift in ways very silently before
Mm-hmm.
anything kind of overt or apparent happens. So there are when our estrogen levels go down, our arteries they become less compliant, meaning they get stiffer, right? And so that's why
Mm-hmm.
we start to see our blood pressure go
Mm-hmm.
up, and that's why
Mm-hmm.
it's that it we start to decrease our production of nitric oxide, which again helps kind of the compliance around
Mm-hmm.
the arteries. It also
Mm-hmm.
helps, like not helps. Well, estrogen helps to um, when it helps the production of nitric oxide also leads to some of the vasodilation and the relaxation in our
Mm-hmm.
cardiovascular system. And think about it, if it's really rigid, it's
Mm-hmm.
going to be more prone to causing problems for us. When you have plaque formation on a rigid system, it's that
Mm-hmm.
inflammation is just going to continue on, right? And so
Mm-hmm.
we don't necessarily think about these things because, again, it becomes that it's a very silent picture. But
Mm-hmm.
not recognizing that until the sharpest end of the stick is often why heart disease becomes a leading cause of death, because we've just
Yeah.
identified it way too late. And this actually connects
Yeah.
directly to everything we talked about with PMOS, because that
Right.
hormonal and metabolic environment that drives insulin resistance, the
Mm-hmm.
androgen elevation, and the inflammatory load also contributes to cardiovascular risk. Those aren't
Mm-hmm.
separate systems. These are the
Right.
same system, just expressing
Right.
different organs.
Right. Different organ. Yeah, that you just mentioned the very important, also the timing within the 10 years from the menopause. It's very important to look at your estrogen level and make sure if you're depleted to make sure you're not depleted in that estrogen also. And I know you briefly mentioned that too in the before. What symptoms should women in their 40s or 50 actually be paying attention to that might be just brushing it off?
Yeah, it's the symptoms that we often file away as
Mm.
stress or perimenopause or just
Mhm.
aging,
Yeah.
unfortunately, right? We could have
Mm.
profound fatigue again that doesn't resolve. It's just this tiredness and this ongoing
Mhm.
depletion. It could be
Right.
shortness of breath, climbing
Mhm.
stairs that wasn't there a
Mhm.
year ago.
Mm.
Jaw pain or
Right.
arm discomfort that they've been attributing to, man, maybe I slept on the wrong
Mhm.
side or slept funny, but
Mm.
it persists.
Mm.
And
Mhm.
then palpitations that come and go. And sometimes,
Right.
we mistake that for anxiety or caffeine.
Mhm.
So it's something
Mm.
to pay attention to,
Mhm.
and even nausea with physical exertion. Like the danger
Right.
is what we attribute that to. And so
Mhm.
the clinical question is whether anyone has actually ruled out a cardiac driver. And most of the time, nobody has because the conversation never comes up.
Right. Yeah. Okay. Definitely. And what would you tell the woman who just got normal cholesterol panel and thinks that she is in the clear, like nothing's wrong zone? What would you tell the woman?
I
Any
would tell her
insights
that
on that?
normal is not optimal. And
Optimal.
normal,
Yeah.
I'm going to use air quotes here, um,
Mm-hmm.
is based on a population range of the average American. Lots of average Americans, but if you consider
Mm-hmm.
that, I think the latest
Mm-hmm.
statistic is that 93% of Americans have metabolic dysfunction.
Mm-hmm.
So we're saying we're normal within that range of metabolic dysfunction. That's a problem, right? Um,
Yeah,
it just means
that's
that
true.
it, the what the standard medicine has kind of been designed to capture is
Mm-hmm.
that threshold, and you kind of fit within there. But like a classic textbook case of normal cholesterol doesn't necessarily mean that you're in the clear. It's not a cardiac clearance. Um, you could have a normal total cholesterol, you could have a normal LDL level, you can have a good
Mm-hmm.
HDL level. These are the HDL is the protective ones, but we have to take a look at the quality of the cholesterol too. And so we call this a lipid fractionation. And that just basically means what's the breakdown? So
Mm-hmm.
cholesterol, we want it to be these big, buoyant, fluffy kind of cotton balls that are running around in our arteries, and they just kind of bounce off the walls and they just go along their happy way, right? The larger, the better. Um,
Mm-hmm.
the smaller ones are the small little beady ones that stick to the arteries, and then that's what
Mm-hmm.
starts to cause the inflammatory process and becomes atherosclerosis and plaque. And
Mm-hmm.
so if your total numbers are fine, but the density or the quality of your cholesterol is awful, you still have an
Mm-hmm.
elevated risk. So I had a
Right.
totally normal panel, like my numbers were beautiful. And then I got a lipid fractionation and found out that the number of LDL particles that I have was sky high, and which
Oh.
meant that I had more small particles than the large
Mm-hmm.
buoyant ones. And even though my HDL numbers were good, the quality of them, they weren't the large fluffy kind that were high. It was the dense ones. And those dense HDL, even though it's still categorized as good HDL,
Mm-hmm.
they're not as protective. They don't function as well. And so we think that
Mm-hmm.
we're in the clear, but we're not. And so what I would say, if you just got a normal cholesterol,
Mm-hmm.
great, let's keep going, right? And so
Yeah.
what do we want to find
Uh-huh.
out? We want to know what your LDL fraction, your lipid fractionation is. What's your,
Mm-hmm.
small, medium, large particles of LDL and HDL, and your VLDL, which is a very dense LDL. I want to
Mm-hmm.
know what your apolipoprotein B is. And that is not something that is on a typical, it's also cholesterol particle. It's not something that's on your standard panel, but it is a very good predictor of cardiovascular risk. There's
Mm-hmm.
also, like we mentioned before, fasting insulin and the
Mm-hmm.
HSCRP, the high sensitivity CRP,
Mm-hmm.
which gives you a good picture of what is the inflammatory condition in your body. Because again, that
Right.
inflammatory load, that inflammation is what is a driver of the cardiovascular risk. So, and once
Mm-hmm.
you know all that, then you could change certain things about your
Right.
diet, about your
Yeah.
lifestyle, so that
Uh-huh.
you can move it in the right direction. So just
Right.
because it's normal, um,
Mm-hmm.
don't just settle there for that. It's kind of like taking your financial retirement portfolio and
Mm-hmm.
managing it on that single data point from, like, 10 years ago, or 2 years ago. Even 2 years is enough of a fluctuation for us, right?
Oh,
We don't approach our finances that way. And so your
mm-hmm.
cardiovascular health deserves the same kind of precision.
Mm-hmm. Right. That's great. This is a good information for a lot of audience. Women 35 to 55 definitely needs to hear that, they want to look for the optimal picture of their own health, especially for heart. So everything we have talked about, the hormones, the gut, the heart, there's a framework that holds all of it together. And I want Grace to walk us through how she thinks about it as a whole picture with your framework also.
Yeah, absolutely. And, I want to be clear about something before I describe this framework, because I built it for healthcare executives, people leading
Mm,
teams and organizations and systems under sustained high stakes pressure. Because to me, when
mm,
the leader is impacted, that trickles down to their team, and
mhm,
what impacts their team ultimately impacts patient care. And so
mm,
that was, my heart and the intention designed in it, because that's who I was too, right? But
mm,
every woman in this audience, every single one of you like listening to this is leading
Mm-hmm.
something under high stakes pressure. It's a family, it's a career, it's a
Mm-hmm.
household, it's your own health while you're managing everyone else's. And so your biology doesn't ask you for your title before it decides whether to run out of capacity, right? It only asks what load you're carrying and whether the structure beneath it can actually.
Mm-hmm.
So while I use this framework with executives,
Mm-hmm.
don't think that it's not for you just because of that title, if you will, that role. The physical roots at its foundation is equally relevant to any woman running a high demand life, which is pretty
Oh,
much everyone watching this, right? So
yeah.
let me walk really briefly through the 6 dimensions. And this framework is designed around the analogy of a tree. So picture a tree in your mind as we go along. And I'll walk through them briefly because the sequence also matters. And so we start with your physical roots, the roots of the tree. I always start at the physical level, like without exception. Hormonal balance, metabolic function, your gut health, your inflammatory load, your sleep architecture, the energy systems at the cellular level. Like before I do anything else with the client, I want to understand the biological foundation beneath every other dimension. Because if the roots are compromised, and again, think of this tree, the roots are compromised, everything built above them is also compromised. And the mental function, the emotional regulation, the relationships, the results, all of it is downstream of biology. And most approaches to health and wellness and even executive coaching start oftentimes at the top, right? The habits, the behaviors, the outcomes. And what I found is that both in my practice as well as my own body is that the gains made at the top don't hold if the foundation hasn't been addressed. And so they require that constant willpower to sustain because the structure underneath it is all depleted. So we move from the roots to the trunk of the tree, which is the mental dimension. That's your cognitive capacity, your decision-making quality. It's the pattern recognition under pressure and your ability to hold all that complexity without collapsing it prematurely. Brain fog is not a personality trait. It has a biological address, and it almost always starts in the root. Then we move to the branches of the tree, which is your emotional dimension. This is all about your emotional regulation, your stress response, and the gap between what is happening internally and what someone is able to show externally. So the woman who appears completely composed while running on empty, we identify that, right? Who manages everyone else's state while your state is you have no framework of your own to kind of build and restore that. That's where the emotional, the branches live. Then we get to the relational dimension, and I look at the canopy of the tree, like the kind of the extensions where the leaves are, as far as that relational canopy, because we also have to reach out to people, right, and make those connections. And this dimension is how all of the above components are affecting relationships at work, at home, with yourself, right? And so when the roots are depleted and the branches are strained, the canopy is the first visible sign. You start to see it in the leaves. You start to see it in things starting to kind of wither away. That shows up in us as a short fuse, or in some cases, you just withdraw, you isolate yourselves. And the relationships that start to feel like they should support you start to feel like additional demands. They're pulling from you. The final the near final, the 5th dimension is the leadership root. And again, this is for my leaders and the executives. And this is about the visible results, the performance that we're responsible for. And it shows, and the way it also kind of shows up in how somebody shows up, not just as the leader or their title, but as a mother, as a partner, as a professional, all the outputs that the world can see. And this is what most people come to me trying to fix, right? They want better fruit, but what they need is healthier roots. And the final dimension, and this is probably the newest dimension to it, is the environment. Right? This is the dimension that most people don't really think of when they think of their whole health picture. Not only the physical home, but the work environment, the toxin and the chemical load. What's the light and the air exposure, digital exposure, your sleep environment, all of that, nutrition, right? And what you're even able to access as far as good quality nutrition goes. That broader structural ecosystem a woman is living in and performing inside is so incredibly important to address, because we can't thrive in that kind of environment.
Mhm.
And again, for working moms in particular, this is the most overlooked and the most actionable dimension because you can take every
Oh.
supplement out there and follow every protocol, and you can
Mm,
still be depleting yourself faster than you can recover
mm.
because the environment just keeps, you know, taking it out of you. And,
Right.
I say you
Yes.
can't out supplement a depleting environment.
Hmm. Oh, yeah, that's very important. Definitely. Where do most of the women you work with show up on this framework when they first come to you?
Yeah, they're typically depleted in their physical roots, and it's been masked by years of just sheer determination. Like you grit and bear it, right?
Mm,
Women who are cognitively high functioning, because that's oftentimes the last thing to go for them, but whose
mm,
energy and their hormonal balance and their sleep and their gut health are all significantly compromised. They come to me
mm.
talking about the fruit, and I ask them to look at the fruits for the roots first.
Roots. Yeah, I see. Wow. Okay. And what does working with you actually look like? And what's the first step?
Yeah. So the first step is what I call the vitality strategy session. And it's that functional medicine intake that I talked about earlier that most women have never
Mm,
experienced. And again, it's not because the conventional providers are bad, it's just they don't have time
mm,
for it. And oftentimes they don't have the training for it either because it's not the kind of approach or perspective that conventional medicine teaches. But we spend,
mm,
again, 90 minutes looking at the whole biological timeline in your matrix, that your symptoms and everything that's accumulated. And so most women leave knowing more about their own biology than they've learned in the
mm.
last decade of appointments combined.
Yeah.
And so, Sandy, I'm sure you can share the link at the close. But what that
Mhm,
can also translate into is if it's the right fit and if it's the right work for the woman, it could lead
mm,
into health coaching, primarily, or it more kind of it goes into a different path of executive coaching. And even in
mm,
my executive coaching program, I infuse functional medicine in there because that's just the
mm.
philosophy that I approach it from.
Oh, wow, that's awesome. And how is this different from just seeing regular functional medicine doctor?
Yeah, I think a couple of things. So one is
Mhm,
I bring a pharmacist lens to every conversation about interventions too,
mhm,
whether that's a supplement, a medication, a botanical compound, or even a dietary change. I understand the
mhm,
mechanism, and so I'm not guessing at what's going to be happening biochemically. The second piece
mm,
is that coaching framework. Knowing what's happening inside your biology is the beginning, right? Not the
mm,
end. And so that work is building the structure that makes the knowledge actionable. And that is important in a real life with real
mm,
demands. That
mm.
combination is what makes this different.
Right, definitely. Well, thanks for sharing your framework. It's very thorough, and there are different areas that you go over with your client. Definitely can optimize their health, which leads to better personal and professional life. So it's good that you are doing this for your client, whether they're in executive position or not, whether because every moms are already leading the family, that's already a leadership position there. And
Absolutely.
that's great. Yeah, that's great that you are doing the service for the women, navigating those transition. And yeah, just to wrap up our session, if anything that we talked about today made some click for you from our audience, if you've been that woman whose lab came back normal, but your body's telling different story, here's what I want you to know that next step you can also take is that I also offer my client clarity call, which is the 45 minutes call. Um, I will be getting all your information, your recent labs, and what you have done so far, and how I can actually help, what's been missing, and what the next step will be looking like. And if that's where you are, like depleted, doing everything right, and tired of being told that you're fine, I will put down the link and the description. And also, Grace. Thank you so much again for being here. And for the women listening who want to follow Grace's work, she is on Instagram, on LinkedIn. Her work lives at the Magedman Group and the Vitality Leadership Institute. She also, she briefly mentioned that too, free resource I recommend if any of the episode resonated. Her leadership capacity scorecard. This is a short assessment, self-assessment, built around her idea. Every woman, like already leading a family, and career, their own health under pressure. This scorecard tells where you're might be quietly running out. So for the deeper session, she also offers a vitality strategy session, the functional medicine intake that your provider never really had time for. So I will put that also in the link in the description. And Grace, if there's anything you'd like to add before we close.
No, thank you so much again for inviting me to spend time with you and your community. And I hope that, this, even if you walk away with one thing, um, just act on it today, right? You are the
Mm-hmm.
CEO of not only your own health and your life, but also of your families, every
Yeah.
single one of you. And so
Wow.
I honor and cherish and appreciate that about you and in your community, Sandy.
Yeah, very good. And thank you all for being here today. And until next time, like Grace mentioned, I hope you all be the one who listen to your own body and take action. All right. Well, thank you so much again, everyone. Bye.
Pretty